Good afternoon and welcome to everybody to the 15th Annual David Rothenberger Lectureship. I'll start by welcoming everyone to, I think, one of the iconic lectureships that we have in the medical school. I'd like to begin by thanking Regent Turner for being here today, and of course our esteemed guests and everyone for making the time in such a busy part of the day. The Rothenberger Lectureship is designed to honor Dave Rothenberger, who really has epitomized and taught us all how to be servant leaders. Dave Rothenberger was a leader in the medical school in many different ways, and for several years led the Department of Surgery, either with a formal title, without a formal title, based on principle and a absolutely enviable work ethic. The Rothenberger Leadership Lecture has hosted numerous speakers across a diverse portfolio. In 2008, former Vice President Walter Mondale delivered the inaugural address, and since then we've had politicians, astronauts, we've had experts and leaders in publishing and medicine and other fields, and most recently, the president of Memorial Sloan Kettering. This year, we're very pleased to have Dr. Neel Kashkari. Before I introduce, Mr. Neel Kashkari, promoted.
My mother will be very proud.
You mentioned that.
Thank you.
Mr. Neel Kashkari as our speaker. Before I introduce him, I'd like to welcome Dr. Rosemary Kelly, who is Executive Vice Chair in the Department of Surgery. She has been an instrumental leader in really coalescing our cardiovascular services and will be taking over the lectureship and will be a key moderator for this evening's event. We also have Dean Jakub Tolar, who really is a instrumental leader in advancing what I believe is clear to everyone, the core mission of the medical school, to improve the health of all Minnesotans, knowing that most Minnesotans in some way are touched by a graduate of the University of Minnesota, and most clinicians are trained here. That combined with our research efforts really makes his efforts as the locomotive pulling us forward so instrumental in driving this forward. And then Neel Kashkari, I think it's important to understand that as the president of the Minneapolis Fed, we should contextualize that the Federal Reserve is perhaps the most powerful economic institution in the United States and by extension probably the world. At its core, its responsibilities are to set interest rates, manage the money supply, and regulate financial markets. Mr. Kashkari is president of the Minneapolis Fed, one of the Federal Reserve System's 12 regional banks, with the district including Minnesota, the Dakotas, Montana, northern Wisconsin, and the Upper Peninsula of Michigan. And in the interest of time, we would encourage you to read more about his background on the Fed's website. For now, we'll move right into the discussion with Dr. Kelly and Dean Tolar. Thank you very much.
Thank you, Dr. Crompton. And it is a pleasure to be here this afternoon, because I've been looking forward to this for a long time. We are here today to discuss the intersection of the Federal Reserve and healthcare sector, and to really honor Dr. Rothenberger with this discussion as we look to developing leaders in our healthcare system who can really understand the whole scope of what we provide to our patients, our state, and our community. So with that, we have several topics we hope to discuss today, and we want to leave time for the audience if you have questions. So we have microphones. I'll be ready at the end of our questioning that we have and our discussion. And please just raise your hand and we'll call on you and have an opportunity to get your comments and questions answered as well. But to start us off, this Leadership Academy honors the concept that Dr. Rothenberger had that physicians as leaders are critical to investing in as a system so that we retain the people who really care the most about our own university. And I would like, maybe if you could take a minute to describe your own leadership journey in the Federal Reserve.
Sure. Well, first of all, thank you for having me. It's great to be with you. Jakub and I have gotten to know each other over the last several years. And Rose and I have just gotten to know each other, but her sister, Kate Kelly, was a on our board of directors at the Minneapolis Fed for 6 years. Really appreciate her service. Let me go back and just give you a little history of the Federal Reserve. So Congress created the nation's central bank, the Federal Reserve, in 1913, and they did something unique in the world. They said they didn't simply want the central bank housed in the nation's capital. They wanted it distributed around the country so that all of the regions of the country had a voice in the policy process. So they created 12 independent Federal Reserve banks, and our job is to represent this region. So a big part of my job is to travel around our region and to understand what is happening in our regional economy. And then I go back to Washington, D.C. every 6 weeks for what are called Federal Open Market Committee meetings, FOMC meetings, and we set interest rates for the nation. Part of what I'm doing in those meetings is talking about what's happening in our regional economy so that our region is represented in that process. You know, we cannot set a different interest rate for Minnesota and for New York and for California. It's one interest rate policy for the country, but my job is to make sure that we are represented in that deliberative process. So I appreciate having the opportunity to be here with you. Healthcare is obviously a huge and important sector of the U.S. economy and of our region, so I'm pleased to have access to such experts as all of you and to learn from all of you. So thank you for being here. In terms of leadership, one of the things that's wonderful about the Federal Reserve, and I know that it's true here too, at the University of Minnesota and in the medical community, is that we are a mission-driven organization. No matter who you talk to at the Federal Reserve, whether it's one of our law enforcement officers, or it's a human resources professional, or it's a PhD economist, one thing that they all have in common is they all believe in our public service mission. We are here to serve the public and advance our economy and achieve the goals that Congress has given us. Similarly, you have your public service mission, serving the patients that you serve, or the university, serving the economy, serving the students, serving the public, ultimately, that we are all here for. So that's, you know, when you work in a mission-driven organization, it is extraordinarily clarifying why we're here. And so that, as a leader, I think that you're off to a huge advantage if the people that you are surrounded by, the people you are charged to lead, are already sharing the same mission that you believe in. You're not debating the mission. The mission is clear. What you're debating is, how do we best achieve that mission given the resources and the constraints that we have? And so for me, I think I try to challenge our other leaders in our organization. Usually people are able to achieve more than they realize. So part of what I try to do is push them to realize, hey, they can aim higher, they can achieve more, and then I will be there to support them. That doesn't mean I don't hold people accountable, but if we are taking calculated risks that we've agreed on, and if it comes up a little bit short, that's okay. The question is, can we learn from that, and how do we do better going forward? And so, I don't know, I mean, I could go on about this for a long time, but I think the fact that we're all in mission-driven organizations is an enormous advantage, because it just aligns us, or it should align us towards a common goal. And once you're aligned towards a common goal, boy, there's very little you can't tackle.
So true.
That's wonderful. You are hired. The job was really good.
Which job is that?
No, it's on my team.
Okay, thank you.
Doesn't pay as well, but you know, it's a mission-driven thing, and you know, I like the concept of the calculated risk, and of course, you know, the ability to pull teams together. And I saw you do that in the financial crisis, and with great interest, I have read your reports on, which was very impressive. You know, how you report on the balance of the inflation and the markets itself. And what was beautiful to me was, whether it was intentional or not on your part, that you actually reversed your course, you know, when the facts changed. You sort of outlined it first and then you went there. So my first question is related obviously to the connection between our two sectors, between finance and between healthcare. And I'm very interested in finance for many different reasons, historically and, you know, currently, because our clinical enterprise is the, you know, largest healthcare system in the state. So as we have looked at the healthcare sector, 4.3 trillion, right? Largest sector in the United States, and connected it to the labor changes, 28% increase in labor, you know, 18% in supply chain, 8% inflation in last. How do these two sectors, that is the finance and the healthcare business now connect in your practice? And secondary question, corollary question, how do you, as the Federal Reserve President and your colleagues, how do you mitigate some of the effects that this enormous sector must have on the finances of the United States?
Well, the first part is, I think you touched on it, which is the labor market. You know, we always talk about, if you follow news about the Fed, you'll hear us talking about what we call our dual mandate. These are goals that Congress has given us, one of which is stable prices, 2% inflation. Obviously, inflation is above that. It's still too high. And maximum employment, as many Americans gainfully employed and contributing to our economy. Normally, we think that these two things are sides of a seesaw. So when the economy gets really strong, the unemployment rate drops, which is good news, but then businesses have to pay up to find the workers and to keep the workers, and then that eventually leads to inflation and the economy gets too hot. In that scenario, we would raise rates to try to cool things down. So when the reopening came, and we thought that, I said this, inflation would be transitory, there'd be a spike in inflation, it would fall quickly. That has not been the case. It's taken much longer than we expected to come down. A big question mark was, what's happening in the labor market and where are the workers? And I'll give you a specific healthcare example. We heard many, many, many stories that many healthcare professionals were burned out in the pandemic. Especially you heard this about nurses. Nurses were burned out, COVID was brutal, they're just throwing in the towel. And then you'd hear other stories that, well, hospitals are now having to turn to traveling nurses, and the rates for traveling nurses are much, much higher than their permanent staff. And all of a sudden, the finances of the hospital are getting turned upside down. Well, the question that I had was, as an economic practitioner, where are all of these travelers coming from? And so the question I had is, are the full-time nurses not giving up nursing? They're just giving up their full-time job to become travelers as a way of getting advantage, paying more, getting paid more. And as an economic practitioner, this is a critical question. Are the total number of nurses in America going down, or are they the same? They're just shifting role. And I could never get clarity, but as an economic practitioner, it's a big difference. If the number of nurses, if we're deficient nurses versus we're simply having to pay them more, my economic analysis of what that means for the US economy is very different. Now, as a hospital system, you may not care because your finances are turned upside down either way. But as I try to analyze the potential of the US economy, the two different scenarios are very, very different. So that's just one example where this is such a big sector of the economy that understanding what's happening in the labor sector, just in medicine and healthcare provision, actually matters a lot to the US economy as a whole.
You touch on the kind of the state of the healthcare providers, and recently we just heard of the Alliance system having unionization be adopted. It's one of the largest unions in the country now for healthcare providers. And obviously that is a reaction to some of the pressures economically for the providers and also in our industry as a whole. And my question to you is, how does this regional event impact kind of the national perspective of what's going on in this region, California, and seeing this rise in unionization and knowing it's going to cause some unintended consequences, some pressures, maybe people will enter the sector, maybe they'll leave it, maybe it'll impact education and how people pay for their training to go into something that may have a very limited income in the future. So as you're looking at these shifts and these pressures, how do you think of those concepts both regionally and nationally, and how it'll help impact our healthcare?
So another very good question, and it's very complicated. I'm going to give you a complicated answer. If you look over the past 40 years, the rate of unionization in America has been gradually declining. Concurrent with that, there's a notion in economics which is the labor share of income. The U.S. economy, a huge juggernaut of the U.S. economy, produces a certain amount of income every year. And some percentage of that goes to workers, and some percentage of that goes to what's called capital, or the owners of businesses. The share that's been going to workers, the labor share of income, has been steadily declining for about 40 years. And that leads to a lot of concern. Like, why is it that the owners of businesses are gaining power, in a sense, and workers are not keeping up? So some people have said, well, the cause is the decline of unionization. Others have said, well, a symptom is the decline of unionization. Is it cause or is it a symptom? I'm not sure. So I guess my big picture is, if in this moment workers are now getting a little bit more of their share or of their power or of their clout, my gut reaction is it's kind of overdue, because for 40 years they've been gradually declining in power. Now, that's not to say that's not going to create uncertainty and challenges for those individual industries that are affected by it, whether it's the autos right now that have strikes going on, or the example that you just gave. And then, so how that shakes out, I'm not sure. Another thing that we look at, this is directly relevant to monetary policy. If you look at union contracts in the 1970s, when high inflation was persistent, most union contracts had what's called COLA adjustments, cost of living adjustments, embedded in the contracts. That's a mechanism by which high inflation perpetuates. Because high inflation is there, it gets paid increased salaries the next year and the next year and the next year. As the central bank got control of inflation in the late 70s and early 80s, and people got confident that inflation was under control, if you look at union contracts, the cost of living adjustments fell away. So another thing that I'm paying attention to in these negotiations are cost of living adjustments getting embedded back in the contracts or not. We've seen some anecdotes that they are, but it has not seemed to be widespread. So that's another dimension of this that's complicated. Last thing I will say, I travel around our region and I will often visit universities and colleges. I remember visiting a community college in Minnesota, and the president of the community college gave me a tour. And I said, what is your most in-demand major? And she said, our most in-demand major is radiology technician. I said, okay, now that sounds like a good job. Why don't you go produce more radiology technicians? And she said, I would love to, but the national accreditation body prevents us from expanding our program because they want to limit the number of radiology technicians in the country to keep wages high. Right? As an economic practitioner, that is illuminating and concerning. And so unionization is one dimension of this, but there are many, many, many barriers that I see keeping people out of good jobs, that if they could fill those good jobs, that would be good for society. And so there's a lot underneath this.
This is cool. I appreciate the complicated answer to complicated questions, because anybody can give you a flippant and easy one, but I appreciate that you don't.
Okay,
that you
thank
actually
you.
Defer to the complexity of these issues. So another complex issue is the corollary to what you were talking about, the people who work in the healthcare. There are also people who are recipients of that care,
As am I.
patients, me, and our families, our communities, and the businesses partake in this as well. And as you, of course, know, the cost of health care in the United States is enormous. And it's to the point, I'm an oncologist, and what is the almost insult to injury in my practice is that not only the young family find out that the little boy over here has leukemia, but they will, in the process of the treatment, and this is middle class, this is not fringes, of any kind, they will lose their house, their parents will lose their house, they will be in medical debt for a very, very long time if this is not easy. So this somehow does not seem right, and somehow, from my study of the history, and also having an advantage of practicing on two different continents in very different environments from this standpoint, this is not necessary. This seems to be almost a historical idiosyncrasy of the United States, that this is, the leading cause of bankruptcy, the number one reason, why people cannot pay bills. And the average deductible is $5,000. 20-30% of a family budget will go to healthcare, whether they use it or not. So how does Federal Reserve Bank, under your leadership, good, right? He's not blushing yet, but dealing with that challenge. Complicated answer is fine.
Yeah, well, I'm going to give you a simple answer, which you're not going to find satisfying, but it's true, which is we have a deal where Congress has said fiscal policy is up to Congress and monetary policy is up to us. And what you're describing is really, these are choices that we make as a society through our elected and political process, whether it's local, state, or federal. So it really is not the role of the Federal Reserve. So that's a convenient answer for me to give. But I will say, when I ask questions like this of healthcare experts, of which you two are healthcare experts, sometimes the answer I get is, every time that we point to other countries and say, boy, wouldn't it be better if we had a system like that? They push back and say no, that here are some advantages. And like if you're really, this is what they tell me. If you're really sick, you want to be really sick in America. That these other countries that we point to that say, oh, look at how great this is, how equitable it is, as long as you're not really, really sick. If you're really, really sick, you have to come to America. So a lot of times in America, we've made a trade. I'm not justifying it, but we made a decision that we want to achieve certain outcomes, but the cost of being able to achieve these very special outcomes is we make these other sacrifices. And other countries might make other trade-offs between that. I'll give you an example. I feel blessed. So my wife and I have two very young children. I'm blessed on many dimensions. One of which is, if you have good health insurance and you live in the Twin Cities, you get great care. I mean, it is amazing. And then I remember when we had our first child was born, and I got the bill from the hospital, and the sticker price on the delivery, my wife had a C-section, I think was $27,000. And our take-home bill was negligible. I mean, I don't know what it was, but it was negligible. And all I kept thinking about is, who is the poor family that's actually going to face a $27,000 bill? Somebody's probably going to actually face that $27,000 bill who cannot afford it by definition. Mm-hmm. And so even just that dynamic of why not make it $270,000? I mean, if you're going to make up a number, why not go for it? Why not make it $1 million, right? So I don't know. I mean, ultimately, I think these are down to choices that we have to make as a society, and I don't know. I mean, this is probably my worst answer I'm going to give you, which is just...
I'm glad I gave you a difficult question.
Yeah, you gave me a
there are many
question.
people, they are struggling with this, myself included. I think that there is a balance, between, what some, say, European countries do and Pacific Rim countries do and what we do here. I agree with you that the best medicine, best medical care in the world, is here. That's why I came here 32 years ago. And that is true. But it's also true that we are moving from healthcare, because very few people want to be in the hospital and have procedures done, to health, which is most people want to stay healthy. That's why you exercise every day and you run the stairs and everything else, because you don't want to be, in my clinic. And that preventative part, by, again, idiosyncrasy of how we calculate the DRGs, the codes, for how we get paid, totally idiosyncratically, we say new knee is much, 10 times as valuable as well-controlled diabetes. And that from medical standpoint or societal or
makes no
personal,
sense.
makes zero sense.
Yeah.
And yet we occupy the system that innovation is unquestionable, that shift from the hospital to home, for example, for care, that shift from having procedures done to prevent them from happening, that is happening. What we are missing is that center, that better system for the healthcare business.
But let me ask you this, because I have a lot of doctors in my family. I've had this debate with my sister, and I've asked her, would she be willing to sacrifice some of our cutting-edge innovation for a more equitable healthcare system? She says yes. Do you think that's a trade we would have to make? Could you preserve the innovation and have more of a equitable provision?
Okay, test question. John Kay. Do you know John Kay?
No.
He's my favorite economist, living, after you, of course. He lives in Oxford.
Okay.
I trained in Cambridge for a bit. And he still writes the column for Financial Times. And he wrote a book that changed my name. It changed my thinking.
Okay.
It's called Obliquity. So my simple answer to this is many complex and complicated problems. You cannot do more of anything, faster, more expensive, more volume, more intensity to improve this. You have to have an oblique way of doing this. And that's what I'm suggesting. We don't have to make a trade-off between the high innovation and preventative care. What we have to have is a better relationship between the payer mix, between the hospitals, between the providers, and actually have a patient for the first time to really be the customer, because at the moment the patient is not the customer in the whole sphere. So I don't think it's a trade-off. It's really how we position the reimbursements in a way that will honor and pay for the preventative care in this case,
Right.
as well as for the innovation. And the last point on that is that the innovation is a huge part of the preventative care.
Yeah. I hope you're right.
Well, if you ask my wife, she would say no, he's not.
Well, I think you're right. It's, as I'm listening to this, and you're bringing up some really important points that, whether it's education, opening up jobs, making sure you have people who can do the jobs, because that will bottleneck some of your delivery of care, and then you're paying top dollar for people when in fact you could just be educating more. And I'm struck by how often one hand does not know what the other is doing. And when you said you meet every 6 weeks with your colleagues, when you said when you're in the Twin Cities, we have great health care. I think that's true for major cities around the country. But we're a big rural state as well. And I know from our patients who come from outstate, who have to come quite a distance, they risk just travel time to get to us for emergencies, which doesn't feel fair. But in many other ways, it feels like regionalization is important, because then you're actually containing costs, skills, education into one region. And it's just a matter of making patients accept the fact they may have to leave their smaller community for better care. Are you seeing any trends, again, across the country where that philosophy of regionalization of medicine is a reasonable consideration economically?
Well, you see it in lots of facets of the economy. There's an economic term, which is a clunky word, called agglomeration benefits, where if you put more people together, you have the benefit that you can have more specialized services, whether it's theater. Like if you're like, I love Shakespeare, well, you're going to need to be in a big city if you're going to be able to support a Shakespeare-only theater. But if a bunch of people are together, you can have Shakespeare-only theaters, and you can have other types of theaters. That's a simple example of that. You also see it in financial services, and education. You see lots of different facets of this, that people are drawn to cities, city centers, regional areas, because they get these rich services it's just a small town cannot simply maintain them out on their own. That's an unfortunate trend that's been with us for a long time. That's probably going to continue to be with us for a long time. Another manifestation of this is you see consolidation in financial services. 20 years ago, 30 years ago, there were 10,000 banks in America. Now there are 5,000 banks in America, and small community banks struggle to compete for related reasons as this. So I think that trend is to continue. One piece of hope is that the pandemic accelerated the delivery of medicine online, like broadband and telemedicine. There were people doing it before, but I think it really jump-started in the pandemic and showed the value of it. Obviously, you're not going to conduct surgery that way, but there's a lot of preventative care you could do by consulting with people remotely. So I think that combined with the fact that Congress is now allocating a lot of money to wire the rest of the country for broadband, I think that shows a lot of potential. So maybe you allow people to live where they are, they get their preventative care delivered remotely, and then when they actually need to come in, then they're going to have to come in, and there's no alternative for that. So I think it's not, like all things, I think it's complex, and it's some trends are probably not going to change, but there is on some dimensions, it's looking more favorable, would be my sense.
Yeah.
Very good. So this is my last question, and then you ask the questions, okay? So just get ready. So related to this a little bit, I think that we have learned from the COVID pandemic that this is a starter pandemic. This is just one of many that will come in our way. And what we have learned, in addition to what you just mentioned, telehealth, we have learned about how to deploy, people from greater Minnesota to our ICUs or not, actually train, have a tele-ICU and have them stay where they are so that they can be taken care of by the teams there. The mental health, that's the only one that did just jump back, I think, because people do prefer, many of them, to be, to have the therapist on the screen, and of course the broadband, as you mentioned, is enormous, in this power. But with the volumes that I have seen, we expected that this is going to be a V-shaped, that people will come, and in fact it's going to be, more of them. It's more like an L, that I am seeing, that it sort of has a new baseline. So my question to you is, what is the role of the Federal Reserve in sort of adaptive capacity buildup now, before the next pandemic, before the next crisis?
Well, so what was the Federal Reserve's role in the crisis? Just to be clear, we did things like we wanted to support the economy. So in March of 2020, you may recall, we ended up cutting interest rates. One thing became clear. We talked to health experts. I talked to Jakub during the pandemic, talked to Mike Osterholm a lot, talked to other experts around the world. It became very clear that the pandemic was going to drive the economy. And the history of pandemics suggested, hey, this is not going to be a few weeks. This is going to be a few years before we're actually through this. And so we ended up doing whatever we could to support the economy. And then something happened. The financial markets actually were at the front end of this, where people were so terrified, not knowing what was going to happen. Normally in a financial crisis, people run to U.S. Treasury bonds as a place of safety. Because the U.S. government is standing behind these bonds. Well, something very odd happened during the pandemic. People fled everything and said, I just want cold, hard cash under my mattress. So the financial system was on the verge of collapsing because of the uncertainty caused by the pandemic. And then what ended up happening in that moment is even the businesses so you knew the services sector was shut down, you knew the travel companies were getting hammered, the hotels were getting hammered, but let's say people were shopping at grocery stores. So companies like General Mills were doing just fine. But if General Mills couldn't access the financial markets,
yes,
then all of a sudden this spilled over to the rest of the economy. So we had to step in to make sure that the financial markets continue to function. So we've now, because we had the financial crisis in 2008 and now the pandemic in 2020, we actually have a pretty robust playbook for what to do if the you-know-what is hitting the fan in the financial system. And unfortunately, these things keep happening. So I feel like we're well equipped if we need to step back in to support the financial system if there is another pandemic. I think much harder is the science, the medicine, what possibly could you do in advance? I mean, yes, you can store N95 masks and whatnot, but can you actually pre-position vaccines and get vaccines? Can you design these things in advance not knowing what the next pandemic is? I defer to the experts on that. But I think the Federal Reserve we have a lot of institutional knowledge at this point at what to do when a crisis hits. But the heroes of the pandemic were the scientists and the healthcare workers. It wasn't the financial practitioners. We had a small part to play.
I would echo the heroism of the frontline workers that we worked with, and nurses and physicians and everybody else. I also would say that, like war, the crisis, the COVID pandemic, didn't really uncover something that we didn't know. We always knew from Ebola and from other things that these diseases are truly, very difficult on societal. It just made the solution inevitable, and that's what happened. And what happened in science, and I won't spend, because I want their questions, but just very briefly, it did accelerate the science enormously. One figure for everything is the Stefan Bancel from reading the code of the COVID virus, the part of it, to the 30,000th evaluation of the phase 3 trial, 286 days.
Amazing.
That is unheard of. I do clinical trials for a living. That takes 10 years,
Yeah.
Easily. So yes, there has been an enormous innovation.
But by the way, on that point, back to the economy. So a lot of people will say, why is there so much inflation, and why was there so much stimulus that Congress provided? Part of the reason there was so much stimulus is because The idea that we were going to have highly effective vaccines within a year was unthinkable when the pandemic first hit. The best experts told us, based on history, that it's going to take several years, if at all. And so when Congress is enacting legislation, they got to plan for a pandemic that's going to be with us for year after year after year. Then this miracle of science happens, highly effective vaccines are available within a year, and all of a sudden the pandemic is shortened. And that's a very high-class problem. But with the benefit of hindsight, that means, hey, the stimulus ended up being oversized. But you know what? I'll take that relative to the alternative.
You made a beautiful point, by the way, how the sectors are related,
Absolutely.
Connected, interdependent. All right, your floor. I cannot see anyone. So.
And just a reminder, we're live streaming this, so it'd be great if you introduce yourself when you ask your question.
Okay, Dr. Ikramuddin, Chair Ikramuddin.
And we have a mic for you here.
I'll defer unless anybody has a question first. Something that I've been wondering about for years that I'd like you to maybe publicly dispel for me is the connection between GDP and healthcare. For years, we have been lamenting. It's the beginning of every course in health economics. We have too much of a percent of our GDP that's spent on healthcare. The more that I've been watching this, I'm not convinced that's a bad thing. In fact, the more I watch this, I think it might be a good thing. If we control for waste, if we control for redundancy, what is the harm of our economy having a significant percentage of its product or output being driven by healthcare?
Well, I'd say two dimensions of that. One dimension is ultimately it's a choice of the citizens of what they are prioritizing. And if they want to choose to, hey, healthcare is our priority, then you're right. There's no harm. That's the choice of the people. I think what causes people to say it's too much is, to our earlier discussion, if you look at some other advanced economies that spend a smaller share of their economy on health, and by some measures have better health outcomes or equal health outcomes, then that implies there must be a lot of waste, and therefore we're spending too much. So you're right. If you can take waste, if you can diminish waste, and the American people want to spend on healthcare rather than travel or rather than something else, then that's for the people. It's not. There's no reason to say that that's bad.
Regent Turner. Okay, can we go to Regent Turner first, please?
Oh, absolutely. Sorry.
No, she was first.
Okay. Yeah. I want to thank you for that comment because you talk about waste. I'm still an active night shift intensive care nurse at North Memorial. And I have testified multiple times about the situation that so many of the patients that we see, it's the first time they're ever accessing health care. Take diabetes. Somebody finds them down. How often does the patient's story start with patient found down? And I would always, whether it be a Senate committee or a House committee, I would always kind of say how much insulin would cost for that person. A couple of years ago, it was $500 a month. At that point, just for the hospital bed at North Memorial, it was $8,000 to $10,000 just for the bed, okay, a day. And so in one sense, not that I would ever say that any of my patients I'm taking care of, it's a waste what I'm doing. But we spend so much money at the highest end of cost. And in a sense, the healthcare system's broken maybe because of that. I'm pitching for the preventive care, Dr. Tolar, I really am. And will this be the demise, could this affect the economy eventually? The way we practice now?
Yeah, I think it's going to have to change because it ends up crowding out other priorities. So we see what's happening geopolitically around the world. All of a sudden, people are awakened, just Russia invading Ukraine and now Hamas attacking Israel. There's a reason we spend a lot of money on defense, and there's a reason we need to. And other countries are realizing this too. So you're right. It ends up potentially competing with other also important priorities. One other point of optimism, which I'll mention, and you can tell me if I have it wrong. I was stunned to recently learn that something like almost half of Medicare patients are now participating in Medicare Advantage. And why I find that is remarkable is that it's a program, I understand, is not without challenges, but it's a program that is designed to align the incentives to get at preventative care. So it's at least it's a source of optimism that it has potential to actually say, let's get to patients early before they end up in your emergency room, so that you can treat them at a much lower cost way. So that's a source of hope, I would think.
It is. Yep. Go ahead. Let's see who that is.
Thank you. I'm David Satin, family doc here at the U, and the newest co-director of the Rothenberger Leadership Academy. I want to ask you a personal question. Like many of us, I'm sure you get a lot of feedback for any of the decisions you make. How do you separate the wheat from the chaff and tune out the less constructive criticism from what you maybe really should be paying attention to?
Good question. I think you got to look, for me, look at the sources, like what's the vehicle, the channel. If it's coming through Twitter, right now there's a lot of people on Twitter no doubt commenting on the stuff I'm saying and objecting to things I'm saying. I'll give you an example. My first time being in any kind of public role was when I was announced to oversee the TARP program, the Troubled Asset Relief Program, to bail out the banks in 2008. I was 35 years old at the time, and social media was just getting started. And all of a sudden, out of the woodwork on social media came all of these people like, oh, I hate that guy. I'm like, I haven't done anything yet. I mean, I can understand hating me after I've done some things, but I literally just got appointed, and I already hate that guy. So, you take that with a grain of salt. But I think you have to discipline yourself. Like all of us are imperfect. We all make mistakes. We never make all the calls exactly right because there's too much uncertainty in what we're facing. So I've tried to discipline myself by saying I have to force myself publicly to admit when I'm wrong. So a year and a half ago, I wrote an essay. I'll give you an example. I read a lot of American history, especially world history, but mostly American history. There's this famous telegram that Abraham Lincoln sent to Ulysses S. Grant after General Grant captured Vicksburg. Lincoln had disagreed with Grant's approach to taking Vicksburg. And after Grant did it, and he succeeded and he took Vicksburg, Lincoln sent him a telegram and said, I want to formally acknowledge that you were right and I was wrong. That's very powerful, because if Abraham Lincoln could admit that he's wrong, so can you and I. And we're not Abraham Lincoln. And so I try to force myself to be disciplined in, hey, if I got it wrong, own it. I got it wrong, learn from it. And I don't know. I guess I don't have a better answer than that to figure out which critic to accept and not. If I would never admit that I'm wrong, then I would be much more sympathetic that the critics are probably right. If I'm disciplined enough to admit when I'm wrong, then, I don't know, it helps.
I admire that answer. It's a beautiful answer. Dr. Yu, you had a question.
Thank you. This is Bevan Yu. I'm head neck surgeon and the CEO for UMP. You mentioned payers. I wanted to probe a little bit about this.
I mentioned what?
Payers, healthcare payers,
yes.
Health insurers. They obviously influence our healthcare system quite a bit, and I would imagine that most of the influence over payers is going to be in the hands of those who control fiscal policy. But do those who control monetary policy have any tools to change the balance of how money flows in healthcare?
Unfortunately, maybe you'd say it unfortunately. No, I don't think we really do. Our tools that we use are so blunt that they affect the economy as a whole. We can do research on various sectors of the economy, and we do, to illuminate these various issues, but we don't have any tools to try to direct that. I'll give you an example of something that's related to that I've become aware of recently. I've seen reports recently that said that Medicare spending nationally has been coming in lower than forecast for basically a decade. And that seems odd, because I thought healthcare costs are going up and up and up. And as I started asking very basic questions about it, what I've concluded is that Medicare is not covering the cost of the services that are being delivered. That cost is being borne by the private sector, and being borne by private insurance. And that's why you hear businesses seeing their private insurance premiums are soaring, in part because they have to cover the costs that are not being fully reimbursed from Medicare. That's a heck of a, that's not a very constructive dynamic, I would say, for the private sector to try to bear that burden. So that's an example where, as a country, we have to confront it and make some decisions about that. It's not sustainable that you can simply say, we're just going to layer these costs onto the private sector and premiums are going to go up and up and up. And so I wish I could give you more, or wish I could tell you more than that.
Thank you for the great lecture, sir. It's Brian Reinbold. I'm a perfusionist here in town. When you talk about the tools the Fed has at its disposal to affect the economy, it seems the last 40 years plus it has relied solely on the interest rate, which is a big hammer, especially to the rank and file healthcare provider across the system and across the country. Concurrent with that, seeing as corporate and boardroom America understood that that would be the rate limiting step rather than taxation on a true profit evaluation, it kind of ran amok and got away from the 33% footprint where historically it was 33% would go into bigger footprint, 33% in return to shareholders' dividends, 33% into workforce expansion. Concurrent, as you noted, there was the demise of the worker in this whole situation with drop-in unionization, et cetera, for 40 years. So I appreciate the fact that you say, you know, it's past due, but at the same time, we fall back to the same blunt instrument, the WAP with the interest rates, that it sets them right back to where they were prior to any gain.
So I would separate out, we talk a lot about cyclical trends, which means short-term fluctuations in the economy, versus secular or longer-term trends. These secular and longer-term trends are really set by, going back to our political system, the choices that we make through our elected leaders. How much do we want to tax? Who do we want to tax? What activities do we want to tax? And then what do we want to spend those tax dollars on, whether it's local, state, or federal? So we at the Federal Reserve have a job to do, which is managing inflation and employment in the short run, but the long run trends that you've highlighted and that I talked about earlier, those are true, you're right about that, but that doesn't absolve us from needing to address the situation in the short run. It's a little bit like, I'm going to give a very, very crude analogy. You could imagine to the diabetic patient or the obese patient, there's a long, big, major health issue that this patient has to address, but when that patient shows up in your clinic, you have to address the acute problem that they're facing right now, which is related but distinct. Our job is to address the economy in the short run. These longer-term structural issues are very real, but we do not have the tools at the Federal Reserve to address them, other than the research that we do to try to shine a light on what these issues are. We just simply do not have the levers or the mandate to try to address those.
Hello, Bob Acton, one of the pediatric surgeons here. I'm curious, from your opinion, how our region, when you go to your every 6 weeks meetings and you advocate for our region, how our region might be different or varies from the other 11 regions throughout the country, and how our interests may be slightly different from theirs.
Yeah, it's a great question. Our region is a little mini United States of America because our region is diversified economically. We've got obviously healthcare, we've got manufacturing, a lot of ag, we've got commodities, we've got some tech, some services. So in many ways, what happens in our region is a little bit like what happens across the country as a whole. So that actually makes it very interesting for me as my job, because as I travel around our region, I feel like I have a pretty good sense of what's happening nationally just based on what's happening here in our region. So for example, if North Dakota and the oil sector is down, other regions of our economy are probably doing better, which counterbalance that at the same time. And that diversity helps. One thing that's a curiosity that I can't really explain is that Minnesota's inflation is back down to 2%. We're one of the first regions of the country where inflation, according to the official statistics, has already returned back to our target. I tease my colleagues that that's because the Minneapolis Fed is doing a great job.
Oh, they like you already.
I know. It's not true. I wish it were. But But I think if you went and asked most families in the region, hey, is inflation back down? I bet they'd tell you no. And so, yeah, it's a little bit of a curiosity. So there's some things that are different, but I think overall we look a lot like the country as a whole.
All right, our last question then.
Okay, I'm Dan Weisdorf. I'm a hematologist oncologist, and my education comes from reading, economic education comes from reading Krugman in the Times. And he periodically admits that he had some things wrong. But he also emphasizes that there's a lot of buzz and spin that says inflation's still too awful, even when things are coming down. So people think everything's more expensive. Now, healthcare, patients don't choose when they get sick, and they don't choose except to avoid care altogether. They don't choose what to pay for it or, frankly, really where to go, because we have a system where the people who pay the bill are not the people who need it. I can choose to buy an expensive car or a cheap car, but I can't choose whether or not to go to a cardiologist if I get a heart attack. So how weird is the discrepancy between the user and the provider of the funds for the services in healthcare compared to other segments of the economy?
Yeah, I think that's right. I mean, I think you're right. People are generally price insensitive when it comes to healthcare, because if you need to go to the doctor, you need to go to the doctor. Maybe not so for some elective procedures, but generally speaking, if you're sick, you're sick. And you're totally right. It's like, go back to my example where we got the bill from when we delivered our $27,000. By the way, the $27,000 was the undiscounted price. Then our insurance company got the discounted price of like $10,000 or $13,000, and then we had whatever it was, $500 was our something nominal. And again, the poor family, whoever got hit with that $27,000 bill, it's really unfair and really devastating and a curious system that we have. But you're right. I don't know any other part of our economy where there's this weird paying system. By the way, where did this come from? It came from the World War II, when they put controls on people's wages and said, well, you can't raise wages because we want to keep inflation in check, but you can give people health care. And this system, I think the system was created then. And you make these decisions in times of crisis, and then you live with them for 100 years, 50 years later, 100 years later, and it leads to all sorts of curiosities that we're still trying to wrestle with right now. Again, I mean, great question. I wish I had more insight to offer you.
Well, I want to thank Mr. Kashkari and Dean Tolar for being here this afternoon. It's been a great conversation, really thought-provoking. I personally have learned a lot, and I have a lot to think about, so thank you for being here. And I want to welcome people to a reception afterwards. We'll be just out in the foyer. And again, you can access this link, share this link in this conversation through the Fed site for Mr. Kashkari. But again, thank you for your time.
Thank you. I really enjoyed it. Really appreciate it.
Thank you.